So this video is going to be over a little bit pieces and parts of things that we need to cover prior to getting into our thoracic lecture. So we're going to talk about laryngectomies a little bit. Then we're going to talk about intubation and we're going to talk about tracheostomies. So kind of a hodgepodge of things that all work together to kind of give us our overview of what we're doing. Now, before you proceed any further, I need you to stop this. I need you to go to your PowerPoint and I need you to watch these two videos, especially the first one. What this video does is an overview of how we produce speech, right? How we produce air from our lungs up through, so it going through the larynx. And it also kind of goes through how we produce our speech in how we're breathing. So before you get into the rest of this video, I need you to go back. I need you to watch this. It's about 5 minutes long. And then on the bottom one, it actually shows the muscles of the larynx and how they pull the vocal cords apart to produce sound. So that's step one. Once you do that, come on back. So after watching those two, you understand that the larynx is an area that as the air goes through, it actually goes through and actually vibrates the folds of the vocal cords. And that's what produces our sound. So it's divided into three different areas. We have our supraglottis, our glottis, and our subglottis, right? And those are the different components that make up our voice box or our true vocal cord. So the trachea itself is actually below that. So this is where we need to get a good understanding of we can breathe and we can talk, and they involve the same areas, but there's very distinct differences. So the reason why we would have an alteration to our voice box, to our larynx, have to do with laryngeal tumors. So we have ones that are benign that are called papillomas. Those can sometimes be caused by HPV. They can sometimes be caused by overuse. And then we have our true cancer. So 60% of our cancers and our larynx are going to be in those true vocal cords with a couple other things involved as well. So we have the actual little tumors. We have some polyps and nodules. So sometimes you'll hear in the news about certain performers that need to have polyps or nodules removed because after a while, when they clap together, those vocal cords develop calluses or polyps or nodules that need to be taken off. So, if you have laryngeal cancer, we know a lot of it is caused by changes to the mucosa, most often by cigarette smoke, either yourself or exposure to chemicals as well. And it begins as carcinoma in situ, right? CIS is what we're going to call it. And our most common type is our squamous cell, and it can progress very quickly if untreated. So, here's the problem though, is that there's nothing outward to see, right? We don't see a mole changing. We don't see a growth. We don't have weight loss. So for our people that we need to screen for this are our tobacco users. That's our number one risk factor. Our African American men, anybody who does smoking and drinking, because that really doubles your risk by like 100 times. Or people who have, again, chemical exposure, HPV exposure, malnutrition. But the problem is that tumor also affects our airway. So the primary thing that we see is airway obstruction. Now, it gets a long time till it gets to the point where it is obstructed. However, we might not see signs prior to that. So we can do a laryngoscopy, and I have a little video there you can watch, and that actually goes down and it visualizes the larynx, and it looks at the vocal cords, it looks at the tissue surrounding. That's our supra and our subglottis. And then on the bottom, it shows a nodule, right? So we have our two different severities, hopefully diagnosing and finding it before we get to the cancerous part where we have an obstruction, okay, where that tumor is so big. If we find a tumor, a lot of times now we can use chemotherapy and radiation. We can try to shrink it. We can get the medication we use most often is called cisplatin. That's the one that we kind of see most often. But it used to be that this was a much more fatal type of cancer. But now we're really finding a good way to get ahead of it, to remove it, to shrink it, to do whatever. So radiation is what we really like to do if we find it early because it's super effective. And it preserves the voice, right? It preserves your ability to communicate. So we a lot of times we'll use the radiation, we'll mix it with the chemotherapy, and it really preserves having to take the next step, which is a laryngectomy. So we don't want to get to that point, and we're finding less and less of the population actually needs to have this, where it used to be much more common because we're able to have a better prognosis with our less invasive. So if we do have to have a surgery to remove part of it, our goals are we want to get rid of the malignancy, still keep the airway open and patent, and we want to make sure that we don't alter the cosmetic appearance, right? Unless we have to. But um, if we have to, obviously that's an option we need to take. So the laryngoscopy, if you go back and watch that video, you can do it outpatient. You can go in, it can diagnose, it can also remove and take biopsies. It can be done vocal rest for about a week or so. And you may need to have a temporary tracheostomy just because of the swelling, because that's the thing. Speaking may also affect our breathing. So we need to make sure we're understanding the difference. Okay. So if we have to have surgery again, kind of like with the pediatrics, right? Least invasive to most invasive, we try to take out as minimal as we can to preserve the voice. Um, you will have to usually have a tracheostomy afterwards. Again, all the swelling and the edema through here. We want to make sure that we have that airway patent, and we want to make sure that you're able to swallow. So again, swallowing, breathing, speaking, all very closely tied in here with our trachea and our esophagus and our larynx. If for some reason the swelling is ongoing, we may need the tracheostomy a little bit longer, or we may need to just to tube feeding to make sure that we have adequate protein and nutrition for wound healing. Our worst case scenario is we would have to remove the entire larynx. Okay. And that is when we would have to take out the epiglottis, right? And that protects us when we're eating, our thyroid cartilage. And what they do is they go in and actually separate our trachea and our esophagus. So when this happens, we've lost all of our speech. Okay. There's no air that is now going up through our larynx, and we're not able to produce speech. So, because of that, we have a permanent tracheostomy as well as a laryngectomy. So, in this instance, you are no longer breathing through your nose and mouth. You are no longer speaking. You are doing all of your air through this opening in the neck. Okay. So, in this video, it actually is an animation. So it takes it layer by layer and it actually shows you through the skin and the fascia and the muscle and the fat. And it actually shows you how they will remove the voice box. There's also some really graphic videos on YouTube if you're interested. They're interesting, but they're very graphic. Just, if you're interested, you can go through. So here's where we need to kind of get into a little bit more critical thinking. So, what is the difference between a true laryngectomy and a true tracheostomy, right? So, here's where we're going to kind of start splitting hairs and figure out what they are. So, I'm going to show you a video with somebody who's way more educated than me and have him explain what the differences are between both of them.
My name is Nirav Goyal. I'm one of the associate professors in the Department of Otolaryngology, and I'm the director of head and neck surgery here. We think about our senses, and we sight, smell, touch, hearing, but we also think about how we communicate with people and how we enjoy life. And so, really, speaking, swallowing, those are important aspects of living. Unfortunately, when we're talking about taking out cancers that are more advanced and we have to remove the voice box, we really are robbing patients of their ability to speak. potentially temporarily, but in some patients permanently. And so that's really the biggest change that they're worried about. Patients often are concerned about the fact that they'll have a permanent hole in their neck or a stoma, and that's something that also worries them. And so we do a lot of work, and we spend a lot of time counseling our patients about what it is like to live without a voice box. Fortunately, with YouTube and with the internet, a lot of patients who have done well after laryngectomy are very vocal, and it's good to know that we can restore voice for the majority of our patients after this type of surgery. I think there's a lot of things that are different between when you look at a patient immediately between a laryngectomy patient and a tracheotomy patient. Many of our laryngectomy patients will not have an appliance in the neck. They will just have a hole there that looks like it's pretty well healed. There's no connection going up to the mouth, so usually they'll see the trachea coming at an angle as opposed to seeing space going upwards. Many of our patients, we've encouraged them to wear bracelets. So oftentimes they'll have an identifying bracelet that says that they're a neck breather, and having that information is an easy, identifiable, quick way to know exactly what type of patient you're dealing with. I think the biggest challenge with a laryngectomy patient is that we're just not doing as many of them as we used to. So, with the advent of chemotherapy and radiation, for many of our advanced laryngeal cancer patients, we can do non surgical therapy, save their voice box, and cure the cancer. But for those patients that need their voice box removed, it's the only way to cure their cancer. We probably have about 13 to 20,000 patients who are diagnosed with laryngeal cancer every year. And of those, only a small percentage of them have to have their voice box removed. And so, in a population of 4 or 500 million people in the U.S., the number of patients who actually have their voice box removed is very, very small percentage of this. This is called a Larry stent or a Larry tube, and so this is what would sit in a patient if they have a laryngectomy, with the curved portion sitting into the trachea, and this is the part that you would see on the outside on the skin. For some patients, they'll have something called the humidity and moisture exchanger, and that usually just sits in this cup here. And what that does is it will humidify the air as patients breathe in. It acts very much like someone's nose or their nose. Other patients who have a laryngectomy, they may not have a tube that goes into the trachea. Instead, they have a plate that just sits over the hole. And that works in very much the same way as the Larry stent does, where the humidity moisture exchanger fits in like this, and the airway would sit behind it. Then contrast somebody who has a tracheotomy, you can see that this is something that the paramedics are probably very familiar with. There's a plate that sits on the skin, there's a portion that extrudes beyond the skin, and then this is the part that would sit in the airway. They'll have more room above, which will connect to the voice box and to the mouth and the throat. Patients who have a cuff tracheotomy may have a balloon at the end, but not all patients will have a balloon there. So if we take a look at these two devices, you can see that the one that's for the laryngectomy looks very different than that for the tracheotomy. It's much more flush to the skin. Usually it's made out of a clear plastic. In this case, this represents the wall that separates the trachea from the esophagus. We can see the prosthesis in place. And what this does is when air comes through, when they cover the stoma, air comes through and it'll come out the mouth and allow them to talk. Laryngectomies represent a pretty unique population. They're a small portion or percentage of the patients that any of us see, but they have very unique needs and very unique ways of caring for them in an emergent setting. It's not only the paramedics, but a lot of our physician and allied health providers are not familiar with this type of patient, and so we're doing a lot of things within Penn State Health to really educate our physicians about this type of patient and make them more familiar with how to manage patients with laryngectomy.
So if you look at the difference in the appliances, so the tracheostomy, right? The tracheotomy patient, that's what we are used to seeing. So that is where we have the plate, that's where we have the little nub that comes out here. The biggest difference is that they still have the ability to breathe in through their nose and mouth and still have that go down into their lungs. The tracheostomy appliance right here can supplement that, right? So if you would need to be ventilated, you would need to inflate the cuff and you can attach the bag malvask, or sorry, yeah, the ambu bag would clip right on into there and you can inflate the lungs. With the laryngectomy, it actually is separated completely to this point. So no air is going in through your nose and your mouth. Everything goes through here. It bypasses your nose, so your sense of smell is messed up. They have to relearn how to eat, they have to relearn how to swallow, and everything comes through here. So coughing, gagging, anything that they need to do to clear their airway, everything comes through here. Okay, so that is the primary difference between the two. So, which is really unique when compared to what we normally would think of, right? So, the next video I'm going to show you. So, you can see here on, I'm putting to my screen like you can see it. You can see the hole in the neck on the laryngectomy patient. Sometimes it is covered, but again, everything is separated. Okay. So when you have a patient who is speaking, they have some type of a device that then forces the air up that they are permitted to speak in some way. Okay. So there's different ways they can speak, but I want you to get an idea, basically kind of wrap your head around what the differences are. So here is different versions of them speaking.
The first time he had surgery, it was a partial laryngectomy, which means basically just one of the vocal cords was removed.
In the beginning, the partial laryngectomy was done. Um, he didn't want to just go ahead and take both, my vocal cords right in the beginning. He was trying to save my voice box if he could.
I was not concerned at all about losing my voice. I wanted to get on with it and treat the cancer in the most aggressive, proactive way possible.
Unfortunately, down the road, I had another recurrence, so that left him no choice but to do the total laryngectomy.
The surgery involved removing the larynx, also removal of one or two lymph nodes, which were not cancerous, but they were removed as a precaution.
After the total laryngectomy, I was in the hospital for about 8 days.
During the surgery, a couple of skin grafts that were taken from my legs, grafted onto the wound site. I can't get back. I was operated. Since that time, I've always had something like this.
The stoma is also a trach, and the trach allows me to breathe as well as to speak. I no longer breathe through my nose and my mouth. I breathe through the hole in my neck. But just learning to take one day at a time was the main issue for me.
So you can tell a difference in their speech. It doesn't sound like a normal speech does, but they are able to vocalize in a way that you can understand them fairly well. And there's several different options that they can use, right? So if we're looking at a cutaway side by side, so on the left, you're going to see our normal neck, right? Our normal, there's the esophagus, there's the epiglottis, the larynx, into the trachea. For a tracheostomy patient, everything from here up stays the same. The difference is that we interrupt and we have a little access way into the trachea, but everything stays the same. Their breathing, their swallowing, their ability to pass air through is okay. Tracheostomies could potentially be reversed, right? If we have it in there, let's say you have somebody who has anaphylaxis and we put a trachea or tracheostomy in and whatever is edema goes away, they take it out, everything is restored. Contrast that with the laryngectomy and look at how much is actually removed for these patients, right? So it still is a component of a tracheostomy, meaning you still breathe through it, but then there's also the access point that they need to figure out how to coordinate swallowing. And because they don't have the epiglottis anymore, that's closing off because that trachea is no longer going through that same area. It's now everything is going through the neck. So it's a very different take on it. Okay. So If you have somebody who is getting a laryngectomy, I suggest you look in your book and there's care of client that has one. So our main issues is obviously going to be airway obstruction, right? That's always ABC, airway, breathing, circulation, right? We have to keep that open. The other problem is they're going to relearn how to do everything because they're no longer able to communicate the normal way. Lip reading is all they can do because there's no air even forcing past there to even whisper at that point, right? And again, changes to how they smell, how they taste, how they're going to have to eat. So, a lot of preoperative teaching. Post-operatively, obviously, we want to make sure that we are teaching them how to maintain that airway. That's the important thing. So we have to keep them upright because laying flat, all that edema is going to go to the stoma site. So keep them upright. Make sure they understand. Now, they are not initially going to be able to eat. They're going to have a tube feed until they can relearn how to swallow. They're also going to have to learn how to suction themselves or to how to cough in a way that they can clear their airway, right, through their hole in their neck. And they're also going to need to be also doing that basic trach care, what we think of the stoma care, keeping it clean, keeping it free of obstruction, and how to protect that stoma. Okay. If they do then heal, once they heal, there's different things that they can do to make that speech. So one of the things is called a TEP. It's a transesophageal puncture. And what that is like a little valve. It looks like a little mini trach. And they create a fistula between the tracheal wall and the esophagus. So what that does is a one-way valve. And if you close and occlude, right, which takes a lot of coordination because you are now breathing through this area as well. So you learn how to breathe through there. And then when you talk, it then will force the air from the lungs up through the esophagus. And that creates some vibration and creates some speech. Okay. It's hard to do because you are breathing and talking and coordinating your breath, right? So in that video, you saw them constantly doing this because they can't keep this occluded, right? Like a trach has a speaking valve you can put on there. You can leave that on all day long, right? As you're awake and doing your things, then you take it off. With this, it's on demand. You have to make sure that you're closing it, okay? But it is a one way that they can go ahead and speak. Another way that they can do that is actually a way where they swallow air and then kind of regurgitate or kind of burp. Remember when you were a kid and you tried to burp the alphabet? That type of thing where that produces their speech. The problem is that it's a lot of practice and you can only speak in minor phrases as much as you are able to swallow. Okay. Another one that we have seen, and I think you see this a lot more, in the movies or on TV is the electrolarynx, and that is where you hold the device to the side of the neck, and the vibrations then come out through the neck and mouth, and you are able to speak, right? But it is a very different type of speech. So, looking at these three, right? So, understanding that there is a component of a tracheostomy, meaning you're breathing through your trachea, but at a different access point, but also understanding the difference of the anatomy that is removed and the reconnection point. I want to show you an example of the three different types of speech that they can have. Okay. So, this is real quick. It's just a little short. Um, and this is a gentleman who's going to speak in three different ways using three different devices.
Right. It's Torin, and I have a voice.
So you can see the difference in if they have the manual dexterity, if they're able to tolerate that transesophageal puncture device, and they're able to use that one-way valve as they talk, it is a much more fluent, as opposed to the electrolarynx, which is very monotone, very difficult to understand, but it is easier to use, right? All you need to do is hold it to your throat, whereas the belching is very influent. It's very difficult to keep going with that and have a fluid conversation. So again, what's our nursing plan? What are we going to do for these? We want to promote airway clearance. We want to make sure we promote communication. And this is something that we're going to have to start talking about before they have the surgery. Okay. We need to make sure they have access to a call light or a bell or something that they can let us know again until they get healed enough that they're able to communicate. When they are able to tolerate fluids, they need to start with soft, easy foods rather than going to liquids first. Because soft foods have an easier control than liquids do. So they'll have to even start with thickened liquids. Again, no epiglottis, to try to swallow. So they're not able to choke, meaning the food and the fluid are not going to go down into your trachea. However, there is a real fear of trying to swallow and breathe at the same time because you're not taking a breath, swallow. You are trying to coordinate breathing through the neck and swallowing. And it's very difficult. And so we want to make sure that they have plenty of practice. They want to make sure there's plenty of privacy as they try to figure this out. And we may need to supplement with IV or tube feed until they get started. Then once they are able to swallow and they're able to tolerate foods, then we need to make sure that we're weighing them, we're keeping up on things to make sure that they are sustaining their weight and their nutrition. Okay. If they, for some reason they're not able to do that, then they may have a G tube or an NG tube long term, depending. Okay. Um, Here's the most important thing. With this hole in the neck, you can no longer submerge yourself. Okay. So you can shower, you can bathe if you're covering everything up, but you will never be able to go underwater again. I'm very clearly need to make sure we outline this. So you can still do boating, but you are not going to be swimming, right? Everything else, you can still run, you can bike. There's athletes that still compete, but we just have to make sure they understand like this cannot be submerged. Okay, that's the main thing. Also want to make sure that we are humidifying, just like with a trach. There's no way our nose, our mouth, our nasal moisture helps to humidify before it reaches down into the airway, where they won't have this. So again, they talked about those little caps that they can put on, different ways, making sure the skin is not broken down. So all the things that you would normally do. This is a really difficult surgery. So not only are you altering how you breathe and how you eat and how you communicate, you look different. This will forever be there. So there's some grief. Anytime we call it, we call it anticipatory grief, where they're anticipating this happening. Then there's the reality of it, of this a mutilating surgery. It's altering your sense of self and your concept. And it's something that we really need to adjust to. Okay. I'm going to show you one more video before we go into the true trachea portion. Okay. Um, because I want to kind of establish one before I get to the other. Okay. So this is why it is important for us to understand where we are and caring for people because of situations like this. Okay.
I was in an automobile accident in '09 and had broken my neck. They'd been replaced. I had a 10-level fusion in my neck and I was having trouble with my esophagus. And so they had operated on my esophagus. I went in and had a test done to prepare for another surgery. And that's when they found cancer. They said that they had to do what they call a laryngectomy, which is they have to go in and remove my voice box. And so 2 weeks later, I had a laryngectomy. I was cleaning my TB, which is my prosthesis, inside my throat, and was putting my Larry tube back in, and it kind of got jammed, and I kind of just forced it down, and when I did that, it had apparently caught on the lip of my TB, and it pulled it out and shoved it into my lung, and I couldn't breathe. Like panicked. It's the first time that I had an experience like that. I ran into my daughter's room in the middle of the night
It was pretty actually horrific. She kind of like kicked in my door and she couldn't breathe. So in turn, that was our first emergency with her laryngectomy. So I was in a whirlwind. I didn't know what to do. Called 911 and it was just very frantic.
They weren't sure what to do. They apparently had never had a laryngectomy patient before. We wear a wrist bracelet that says we're neck breathers because we don't breathe at all through our nose and our mouth anymore. And I kept trying to show it to him. And he kept taking my arm and shoving it away. And they were trying to put a mask over my nose and my mouth. And I was pointing to my hole. You can see it. And I couldn't communicate to him what to do. And he didn't know what to do. I don't honestly remember too much after that. I passed out because I wasn't breathing, and it actually flatlined. So I don't remember much more until we got here.
When we evaluated her, I could see that she was having trouble breathing. Her oxygen levels were not as high as they should be. So I took a look at the chest x-ray and I was able to identify that there was something a little bit different in one of the pathways to her lungs. And we could identify a little disc-like structure there, which was consistent with a prosthesis. So with that in mind, we knew immediately that we're worried about a foreign body. Once I saw her, I knew immediately that she had had a laryngectomy. And so I was able to inform the rest of the team or healthcare team that they should not be trying to put a breathing tube through her mouth. And if she needed any extra oxygen, that it should go through the neck. Pretty quickly afterwards, we were able to get the pulmonologist involved, and they were able to use a pretty nifty tool to actually freeze something onto that disc and pull that out within a couple of minutes. Her airway was open, her oxygen levels restored pretty quickly, and we're able to save her from a pretty emergent situation.
So this is why it's important that we understand, because there are becoming fewer and fewer patients that are having a total laryngectomy. So if you come across someone though, you do need to understand what it is that you need to do. So that's why we spend a little bit of time talking about the difference between the laryngectomy and the tracheostomy. Okay, so keep that on the front burner. Now we're going to switch to intubation, right? And so if even laryngectomy patients can be intubated through their stoma. And so what this is where we will take our airway here. So we have our endotracheal tube, and you can see down at the bottom, they've got a balloon on the bottom two, and on the top one, there is no balloon. Okay. So what that is you will pass it either through the mouth down in, you can do it through a trach stoma, you can do it through the laryngectomy stoma. But what it does is it gives you access to the actual lungs and the breathing mechanism. So the difference between a cuffed and an uncuffed tube. So you see on there where it's got the two little blue bladders with the long little string. And what that is you will intubate with that cuff deflated. You will go ahead and pass that down through the trachea or into the stoma until you get further down, and you will actually inflate that. You'll use a regular syringe and inflate the little balloon. And what that does is it seals off so that whatever you are doing as far as bagging, ventilating, anything through the top part, right? The little blue section there at the top of the tube, there'll be no air leakage when that cuff is inflated. That's why it's important to understand the difference between the two. Because if they have an uncuffed tube, then air can still pass around there. So typically, when we're talking about intubation, we are talking about a reason why we would need to bypass anything in this area, whether it is trauma, whether it is anticipating surgery, whatever it might be. But you are bypassing it to get control and be able to breathe for them. Okay. So again, the cuffed tube, why would we need it? What it does is it cuts off any type of air that's going to come back up through. So as you're using the bag, right, onto the ET tube, if it's not cuffed, it could come right back out. So it maintains what we call positive pressure, right? We're the ones pushing the air down in, which is what positive pressure means. And then it makes sure the air stays down there and is only controlled through that tube. So We can use a cuff tube for a while. We can use it for 3-4 weeks or so, right? We wouldn't typically do that, but we could. We don't want the pressure of the cuff to be too hard, because if it's too inflated, it's going to put pressure on the sides of that airway, and it could actually cause necrosis, right? But the thing to remember is that with that cuff inflated, the air is not getting up through that larynx and you're not able to talk. Okay. So this goes back to why we need to know the difference between the laryngectomy and the tracheostomy. Same thing with ET tube. So if you have that airway pretty much occluded, except for the ET tube, the endotracheal tube, that air is not able to pass up through the top to produce speech. Okay. So tracheostomy, many times, if we think it's going to be long term, if we think that you're going to be on a ventilator for longer than, let's say, 7 to 10 days, they will go ahead and put in a tracheostomy. Preserves your oral tissues. It is able to do less damage when we have the weight of that tube. It can actually cause ulcerations. It can cause tissue damage. So we can go ahead and put in that tracheostomy. Okay. So same thing. You can do a cuffed one, but that means that no air is passing up through. So you're not able to produce any speech, right? And when you place it, you are understanding that you are still able to breathe in through your nose and mouth. If the cuff is deflated, you can breathe around it. Okay. You can push air up and around it, still swallowing the same, still eating the same. Okay. And you can put a speaking valve on the end of that tracheostomy. Okay. So when we look at the trach, just like when that gentleman showed for the laryngectomy, so we have different parts of it. Okay. So when you are looking at a trach on the outside, you're only seeing part of it. There's a whole lot more that's going in on the inside. So I'm going to show you what the different parts of the trach are, what they look like. Okay. So let's see here. Got these closed. All right. So here's our speaking valve patient. Actually, I want to show you that one first. Let's go ahead and show the different parts of the trach first.
I'm Dr. Jess Mason, and it's time to demystify the tracheostomy tube. This one happens to be cuffed, and here's the pilot balloon so that when you use the 10 cc syringe to inflate it with air, that cuff inflates. It comes with an obturator, which slides into the outer cannula during placement, which is then removed, and the inner cannula is placed inside the outer cannula. This is the faceplate, also known as the flange. Check the balloon to make sure it doesn't have a leak, and then fully deflate it before insertion. Slide the obturator into the outer cannula for placement. Once properly placed, remove the obturator and insert the inner cannula, which clicks into place. When you inflate the cuff, the pilot balloon will also become inflated so you know that it's working. At this point, the device would be secured in place with a tracheostomy collar.
So there's lots of parts that you see on the outside. So you're going to see that hard hard ring of plastic, and you're going to see kind of like that flange, or that plate that goes over the top of the stoma. So unlike the general laryngectomy where you have an open hole, you actually have that little plastic nub that sticks out. You will also have trach ties, which ties we don't see often anymore. What we see now is more of like a Velcro, like a blue foam strap that's going to hold it in place. If it is a cuffed tube, then you're going to see that little hose that comes down to the pilot balloon, is that where you inflate. If it's an uncuffed tube, obviously you're not going to see that. Either way, if it's cuffed or uncuffed, there's that inner cannula that comes out. So when we do trach care, what we're cleaning is that inner piece. So many newer tracheostomy sites now, many inner trachs have a disposable inner cannula. You take it out, you throw it, you put it back in, a new one. But we're going to actually learn how to clean it just in case. The other thing to remember is you always keep your obturator and an extra trach at the bedside with the patient. If the patient goes to surgery, they go with them. If they go from the nursing home to the ER, it goes with them. It's always at the head of the bed. Should for some reason that trach come out, you put the obturator back in, you put it back in the hole. The reason why we keep it at the head of the bed with the patient at all times is because if for some reason that becomes dislodged, the muscles in the neck are very tight, they're very strong, and they will pull together and they will close that in a matter of minutes. So we have to make sure we have the obturator and the all the components together to put it back in should something happen. Okay, so that's something we have to remember as we keep it together. So when we have this inner cannula piece, we can do some type of suctioning. So because that is going down in the airway, just like we would cough, they need to actually be suctioned. So for your trach care case study, there's a couple different videos that talk about suctioning and how it can be traumatic to the patient, how it's required and necessary to keep that airway clear of secretions, but there's other components and things that you need to consider with it. So when you're doing your trach care case study, please make sure you're being very attentive to what the patients were saying and feeling regarding that procedure of actually being suctioned. Okay. So there's two different types of suctioning. There is open and there is closed suctioning, depending on what your patient has and what their need is. So the difference between those two types of suctioning. So what we will be practicing in our trach care and our trach checkoff or trach suctioning is the open suctioning. And that is where you will get a sterile catheter, a sterile technique. You will attach it to suction tubing. You will advance it down into the trach without your thumb over the suction. So you're going to put it down with no suction, right? Then you are going to pulse and you're going to pull an open suction, right? And you're going to pull out those secretions. The other one they showed is closed suctioning, and you will see that more and more in the hospitals. I did a lot of open suctioning when I was helping students on a trach, a skilled care long-term vent unit at a nursing home. But if your patient is on a ventilator or has some type of a device set up at the hospital, it is inline, meaning everything is all set up. So you will advance the catheter that is involved in like and wrapped in plastic in a closed system. You will advance it. You will press the button to suction as you pull it back out. And then you will use some saline, you'll squirt it in and suction that through to clear the line. But that is much less you're much less contamination. So while it is sterile, it is enclosed. Where the open sectioning, you have to be very careful that you're not touching anything, that you're not introducing it directly into the airway. So that's kind of the difference between the two sectionings. So we will go over that on your first day for trach care when we're getting ready to do our skills check off. Okay. This is a video that you can watch on the trach speaking valve. So what this is very similar to what they talked about with the laryngectomy patient. But this valve you can actually put in place and it can stay there hands free. And when you breathe in, the one-way valve allows you to breathe in. And when you go to speak, it actually again has a one way on it, so won't let the air come out this way, but it'll go up forward toward the top and you can do a hoarse whisper and vibration, and that will cause some type of speech. Okay. And through the nose and mouth, because again, with the tracheostomy, everything is still in place. Okay. In your book, they also have a comparison between, so we've been doing a lot of comparison between the laryngectomy and the tracheostomy, but in your book, it'll do a comparison of the endotracheal tube and the tracheostomy as well. So one goes through the mouth, goes down further, the tube is longer, but the same major components, which is it's got the cuff, it goes directly in, you do all your ventilation through that tube. The difference between the two, as far as the structure, is that the tracheostomy has an inner cannula, whereas the ET tube is only one single piece of plastic, right? So you're not taking that out to clean it. You are leaving it in, which is again a reason why you would leave it in for a shorter amount of time than the tracheostomy, because obviously the buildup of bacteria and secretions. So when you have a patient that is being intubated, whether it is tracheostomy or whether it is endotracheal tube, when you're putting it in, for the endotracheal tube, you want to make sure you are trying less than 30 seconds. Okay. And because this is a long way to get from mouth all the way down into the um, above the lung. Oh my goodness, I'm sorry. You want to make sure you do a chest x-ray to confirm. So when you actually intubate, you're going to actually watch for bilateral chest rise, and you're going to listen to lung sounds, because it's very easy to go down one bronchus as opposed to staying at the top where you can access both lungs. So chest x-ray is going to be absolutely necessary to confirm placement, but just like we do with an NG tube, there's other things we can do to actually see in the meantime if it's working, right? We're obviously going to watch our vital signs. We're going to look for breath sounds. We're going to watch their pulse ox. And we're going to have equipment at the bedside just in case something would happen to go wrong. Okay. So this is just a basic overview. So what I want you to take away from this, I want you to understand the difference. So anything laryngectomy that I mentioned at the beginning, I want you to just kind of an overview of when you do it, why it's required, what adaptations do you need to make, what do you need to do for nursing care. Understand tracheostomy, what the equipment looks like, why do you need an obturator, what's an inner cannula, the difference between open and closed sectioning, and also understanding the difference between a full intubation with an ET tube versus a tracheotomy that is done, and a difference in the equipment. So this will be kind of our springboard. And then we will continue on talking about mechanical ventilation, and a little bit more in depth of thoracic things. So this will be a good place to stop this conversation, and then we can pick up when we move forward with the rest of the conversation.